Hello, my name is James Hartsfield. This is my video assessment for the cardiac and lung functioning. I'll begin by scanning the quick scan of the room. So, there are no materials anywhere. Okay. All right. Now, for this assessment, understand that I will be only mimicking any sort of supine position. We don't have a way to do that here, but in a real world scenario, I would have for lung and for heart functioning, I would have the patient not only sit up, I'd also have them in a supine position, and if need be for the cardiac assessment, also a lateral position as well. Also, in real world scenario, I would have the patient either in a gown or preferably topless, so I could auscultate the lungs and the heart sounds without any clothing in the way. Right, so to begin, for the lung functioning, it will be inspection. As I walk into the room, I will simply be watching the patient's rate of breath, just to mentally start counting for a minute what their approximate respiratory rate is. I will also be observing the AP diameter. I will be observing the thoracic rise to see if there's any abnormalities in that rise. I will also be looking for anatomic landmarks. I will be ask the patient to tilt their head downward. I'll be looking for the C7 and T1 vertebrae. I'll also be looking for the clavicle bones, the axillary, the sternum, the trachea, the angle of Lewis to determine where my lungs are, keeping in mind that the right lung is going to sit slightly higher than the left lung. Again, I'll be listening for any auditory, abnormal lung sounds, stridor, wheezing, anything of that nature. If that is the case, I would ask the patient to cough to see if that clears it up. I'll also do palpation. I will place my hands on the lower portion of the patient's back and have them breathe normally. I'll be observing for any asymmetry in the rise of the lungs to determine if there is anything abnormal in the rate of the rise of the lungs. I also palpate for fremitus. Have the patient please say the word 99.
99.
I'll be feeling for any sort of crackling, any fremitus, either bilaterally or if there's any asymmetrical fremitus in the lungs. And again, in a real world scenario, I would have the patient do this in a supine position as well, so I could feel the anterior lungs as well as the posterior. For palpation, I move in a symmetrical fashion, systematic symmetrical fashion, tapping either on my finger with a quick stroke of my wrist or with the flat part of my hand, moving down one side and then the other side, again in a symmetrical fashion. I'll be listening for resonance and any hyperresonance or tympany, anything that would suggest a mass or fluid or an abnormal amount of air, for instance with something air trapping, say with emphysema or asthma. And again, I would do this on the front as well in a supine position. And again, in the real world scenario, there would be little to no clothing to better hear the palpations. For auscultation, again, it needs to be a quiet setting. Again, preferably little to no clothing. And just like with percussion, you move in a systematic fashion. And it depends on how your system is. You can start with front, the midline, or the back. But however you do it, it needs to be the same every time. For myself, I start with the left side, and just have the patient take a few breaths. And then instruct the patient just breathe normally. And as they do this, breathing in and out, move slowly right to left, down, and then left to right, hitting all lobes of the posterior lungs. Please raise your left arm. Moving to the left axilla so I can hear the lateral lobes as they continue to breathe normally. Please lower your arm. Moving to the anterior. And again, just as I did with the posterior side, start on one side, move to the other. And you're listening for any abnormal sounds, stridor, wheezing, or any rhonchi. If I encounter any rhonchi or wheezing or crackles, especially rhonchi or crackles, I would instruct the patient to cough and then auscultate again to determine if the coughing cleared it. If it did, then it is likely mucus in the closest to the upper respiratory tract. If not, then it's likely fluid that is in the basal part of the lungs, which constitutes possible pneumonia. As I finish with the anterior side, please raise your right arm. Listen to, finally, the right axillary side. This is also so I can attempt to hear the right middle lobe of the lung. Please lower your arm. Moving on to the cardiac assessment. Again, cardiac assessment begins with inspection. Now for the cardiac assessment for inspection, again, in the real world you would have no clothing on so that you could see the bare chest. And more than likely, you would have the patient in a supine position so that you could see any sort of visible contraction of the heart if there's any major issues going on with each pumping of the heart. I'm also looking for lines as here as well. I'm looking for the ribs. I'm counting down if I can. You can count the second intercostal space, which is normally visible in almost every patient, and you'll be looking for the fourth to fifth intercostal space to find the apex. You're looking for the axillary for the lateral border. You're looking for the sternum for the medial border, and somewhere around the clavicle area for the base of the heart. Now I'm going to use my hand for the palpation aspect. I'll feel towards the apex of the heart to, just as I would if I was feeling for a peripheral pulse, to determine if I can feel any sort of abnormalities, what the strength of the pulse is, if there's any sort of thrills that I can feel on palpation.
Thrills?
Finally, I'm going to auscultate the heart, and again, just as with the lungs, you have to start and move in a systemic fashion, and it doesn't matter. It's personal to how you want to do it. It just has to be in a particular order, and it has to stay that order every time. For me personally, I begin with the apex of the heart. Again, somewhere it's going to be about 4 centimeters lateral from the sternal line, about the fourth or fifth intercostal space. You're going to listen for rate, for rhythm, any sort of thrills, any sort of murmurs, any possible regurgitation. S1 and S2 should be clearly defined, possibly S3 and S4. Those may not be heard on auscultation, however. You're also listening for any splitting of the S1 sound or the S2 sound. You're also listening for any sort of, any sort of abnormalities. Like I said, possible mitral regurgitation, aortic regurgitation, or stenosis. Moving from the apex over to the lateral border, up to the base, finally to the medial border. And then one last time, I'll start the apex, and for each auscultation, I'll have the patient hold their breath for a few seconds while I listen. Please take a breath and hold it. And let it out. Please take a breath and hold it. And let it out. And take a breath and hold it. Let it out. And please take a breath and hold it. And let it out. By having to hold the breath, by removing the expiration portion of breathing while you listen to the heart, sometimes certain murmurs, certain dysrhythmias, and certain splitting can be eliminated, which gives you a diagnostic clue as to their cause. This concludes my cardiac and chest and lung assessment for this patient. Thank you.